Thank you very much, everyone, for joining us on World Patient Safety Day. I've got an expert ISWOG faculty here to answer questions about COVID and pregnancy. So I'm really pleased we've got many of the authors of some of the key papers in this area are joining us just now. And you've been very generous with your time in sending us questions, which we're hoping to answer one by one. And we'll have a bit of a general discussion at the end as well. So thank you very much. I'm going to jump straight into the questions now.
First of all, thank you for having me on. This is great. And thanks to ISWOG and everyone. This is such an important topic for pregnant women and COVID. There is evidence that, for example, the Delta variant is more infectious. In general, the data in non-pregnant adults is similar to the data in pregnancy. The important thing is that the vaccine covers these different variants so far, as far as we know. So it's really important, as we'll discuss, to give the vaccine to women. Only about 25% of pregnant women in the US have been vaccinated. That needs to increase. But there's also safety data on over 160,000 women in the US reported to the CDC. So there are different strains that can affect the woman a little bit different in terms of infectious, but the vaccines covered also. I really need to emphasize the need for women to get vaccinated as soon as they can get a handle on the vaccine. And in fact, in the US here, they should even get boosters because some of our women have been vaccinated like 6 or more months ago. So we have one of our fellows who just got a booster yesterday from Pfizer.
Thank you very much indeed, Vincenzo, for that succinct answer. So the answer is yes, there are differences in the different variants, but they're not huge and they are all covered by the vaccine.
It really depends mostly on the viremia, and viremia, so the virus in the blood of the mother depends on how sick she is. So in general, the chance that there is virus in the blood of the woman is 1% or less. So in those cases, if you have a symptomatic mild disease, the chance that the baby gets it is extremely small. If the woman gets really sick, she is critically ill, intubated in the ICU, she has pneumonia, then she has a 30% or higher chance that the virus is in the blood, that there is viremia. And those are the cases in general that have been reported rarely to have transmission through the placenta to the baby. There are receptors in the placenta. The virus can accept that and go to the baby. But again, those are very, very few reports, very rare. I think it does exist, but those babies actually did well. So in the rare, very sick woman who passes the virus to the baby, those babies did well anyway.
Just allow myself a supplementary question to you, Vincenzo, that of course, the neonatologist will normally do a throat swab if there's a COVID positive woman, but of course a throat swab picks up passage at the time of delivery, potential mother to mother to baby transmission, and of course, could represent mother to fetus transmission. So it's all three possibilities, isn't it?
Yeah. So that swab should be done, right away after birth, and even because sometimes these reports are like 2-3 days, and the mother has had the baby, may have transmitted the COVID virus after, birth. Then, you can do cord blood antibodies, and there are some reports with IgM that's been controversial, but that would kind of confirm a little bit the transmission. You could look at the amniotic fluid, and there are very few reports of positive amniotic fluid. So I think that these few reports need to have better confirmation, like you said. It's not just a nasal waft after birth, because there could be contamination, but you could also study amniotic fluid, cord blood, placenta, and other ways to kind of prove the transmission. And there are a handful of good reports like that in the literature.
Now, of course, COVID and preeclampsia are different conditions, but there is some overlap there, and interest in the question of preeclampsia being more common in COVID. Asma, tell us about this.
Well, you're right. The evidence of a link between COVID and preeclampsia is compelling, and that illustrated very nicely by the recent meta-analysis by Professor Romero. So it's not just an association between preeclampsia and COVID, but also the dose-response relationship. So women who have severe COVID are more likely to develop preeclampsia compared to those who have mild or asymptomatic COVID. And for the angiogenic markers, certainly would be helpful in differentiating between COVID and preeclampsia, because you would expect in preeclampsia that the SFLT1 level will be increased and the placental growth factor would be reduced. But what about if we don't have access to the angiogenic markers? In this case, we can rely on other clues. So for example, if the woman have respiratory symptoms or fever, that's more consistent with the diagnosis of COVID. And if she has, we can also use imaging, for example, like lung ultrasounds or lung CT scan, where you would expect to see features of COVID compared to if she has preeclampsia. And of course, preeclampsia doesn't get better until you deliver the baby, while actually COVID, in the majority of the cases, you'd expect to get better with the right support and treatment. But ultimately, you have to treat the patient in front of you. So if she has hypertension, you need to give antihypertensive treatment. If she has respiratory compromise, you need to give respiratory support.